Aloha and welcome to our lecture today. I'm very excited to talk about this topic with you. It is a topic extremely important to the practice of nursing, and that is the topic of physical assessment. So as nurses, we have to assess our patients from head to toe, and we have to document our findings. So we're going to start out by just kind of discussing some of the normal things. So the process of doing the head-to-toe assessment and some of the normal things that we expect to find. And then occasionally we might throw a little abnormal in here and there, but we're really going to dive more into abnormals as we move into the next semester of nursing school. So, with that being said, let's just kind of look at an overview of physical assessment here. And so we know that we're going to be looking at the general appearance and how well our patient's personal hygiene is. We're going to be looking at the skin, the head, the neck, the chest and the lungs, the heart, the abdomen, and the musculoskeletal system. And so we're going to go through each one of these in a little more detail. And when we gather data using physical assessment techniques, there are a variety of ways in which we gather that data. So for example, when we listen with our stethoscope, we call that auscultation. And that's listening with our stethoscope, whether we're listening to the heart or we're listening to the bowel tones. Another type of skill that we use in assessment is palpation. And so that's when we are palpating. Another word for that would be to be feeling, touching, and putting gentle pressure on the abdomen. So when we assess the abdomen, we palpate the abdomen. So we have auscultation, we have palpation. Sometimes we use other skills as well, but we're going to kind of focus on those, and as other ones come up, we'll go ahead and cover them. So let's go ahead and get started. We're going to talk about general appearance first. Okay. So we want to be able to just walk into the room initially and just look at our patient, general appearance and mentation. And what that means is we want to know if they're alert and oriented. So in terms of general appearance, we want to look at them and see if they're well nourished. How can we tell? Does the individual look like they're at a healthy weight just from general appearance? Do they appear emaciated? Which would be extremely thin? Do they appear to be obese, which would be overweight? So this is just your general observation of them. In terms of their hygiene, are they well groomed? Is their hair washed? Are their teeth brushed? Does their face look clean? Are they wearing clean clothes? So this would just be general appearance, right? In terms of orientation to person, place, and time, there are some specific questions that we want to ask. So we want to know if they're oriented and to themselves. And by finding out the answer to this, we ask, can you state your name? And so they state their name. And then we know that they're oriented to self. We introduce ourselves to them. Hi, I'm Mary. I'm going to be your nurse today. Later on, when I go back into the room, I can say to them, hey, I met you earlier. Do you remember who I am, right? If they know who you are, then they're oriented to other people as well, right? But the main first question is, can you state your name? The next question is, can you tell me where we are? So we want to know if they're oriented to place, meaning they could say, I'm in the hospital, I'm at the villas, wherever the location would be, and are they correct, right? So if they tell you that they're on their uncle's farm, then maybe they're a little confused, right? So sometimes people can be oriented to self, meaning that they will know their name, but they may not be oriented to place, so they might be confused about where they are. The next piece would be time. And so the questions here would be, can you tell me today's date? Now, I don't know about you, but sometimes I don't even know the date. So, especially someone who's in the hospital or in long-term care, it's really easy for them to kind of lose track of the actual date. So if you ask them the date and they're kind of like, especially if they were oriented to self and oriented to place, you might say, well, can you tell me what season we're in? Do you know what month it is? They might say, oh yeah, it's November, we're getting close to Thanksgiving. That is a gold star as far as I'm concerned. They are oriented to time, okay? And so what we do is we say they are oriented times 3. We write that in the chart. We write A and O times 3 means they're oriented to person, place, and time. Or maybe you'll write in the chart that they're oriented to self only, okay? And so that's just a little example of how we do orientation. The next thing we would be looking at is skin. And in skin, we want to look at temperature. We want to know if the temperature of the skin is warm, is it cool? Very importantly, we want to compare one side of the body to the other. So is one leg warmer than the other leg? And if so, is there a problem with circulation, right? We also want to look at the moisture of the skin, right? So is the skin moist or is it dry? Is the patient, sweating while they're in the bed? Is the bed wet from their sweat? And so those will be other observations that we want to make. Is there skin that is so dry that it's cracked and it's peeling? So that's something else we want to make an observation for. Of course, we check for the color of their skin. And we're going to look at some examples of that here in a minute. So, warm, dry skin that's pink is kind of what we're looking at for normal, right? Warm, dry, pink skin tells us that the patient is, fairly healthy. And we check for tenting, which is when we pinch and we look for tenting, where the skin stays in that pinched position. That might give us an indication that the individual might be dehydrated. Now, keep in mind, for elderly patients in long-term care, because they have lost a lot of collagen, they often have skin that will tent. So it doesn't necessarily mean that they are dehydrated. So some of the color we might see is pink, jaundice, ruddy, pale, tan, cyanotic. We're going to go through those. We look for skin turgor. Is the turgor good or is it poor? And if it's poor, it's because they're tenting. Although again, remember, we have to consider their age. And then we look for rashes or lesions or petechiae or ecchymosis. And we're going to look at some examples of those as well. So in terms of skin tone, we're just kind of call it as we see it, right? So here we see 3 individuals, and these are 3 very cute kids. But we see that the first little girl is tan, and that's kind of how I would document her skin color. She's tan. Or another way might be that it's appropriate to their ethnicity, right? We see this little guy in the middle, and he's sunburned, right? So I would document it like I see it. His skin is red, but I know that it's red because he has a sunburn. And then our sweet little girl here on the other side, we would refer to her skin color as fair, which means that she's naturally kind of pale, and that's considered normal for her, right? So here we see a couple of examples. This is an example of cyanosis. And so if we look carefully here, we can see that the tips of the fingers and the toes and around the lips have a bluish color. This is a sign of low oxygen levels in the blood and causes this redness, this blueness around these areas. And so we want to be always observing, even for the most faintest, a color of blueness around the lips, fingertips, toes, or that the patient looks extremely pale, and we call this pallor. You've heard people say before they were white as a ghost. That's a little bit different than being fair-skinned, okay? Now, it's going to take some time and some experience before you can differentiate between these things. But here are some more examples of cyanosis. These are peripheral signs of a decrease in oxygenated blood to the extremities. We can see it here in the fingertips and in the lips as well. Another color that we might see on an individual is jaundice. Jaundice is a yellowing of the skin. Sometimes it can be subtle. It's a yellowing of the sclera of the eye, which is usually white. We notice that it looks a little yellowish. And this is usually from accumulated bilirubin in the skin, and it's often caused by liver and gallbladder disorders. So again, we're going to get more into some of this later, but right now we're just kind of introducing what some of the abnormals might be. In this slide, we see some examples of a rash. So if you look at the one that's labeled rash, we can see that it's bumps. They're raised, they're red, and usually rashes are itchy. And so we can find out whether or not this rash that's on the patient's skin somewhere is associated with also itching or pain. And we want to be able to document where the rash is located. On the bottom slide, we see an example of what a lesion would look like. This is a lesion. I think this is an example of like ringworm on a little boy's forehead. And then we see up in the corner there an example of ecchymosis. Ecchymosis is a fancy word for bruising. So this individual has a bruise on their arm here, and that is ecchymosis. Ecchymosis can be purplish, bluish, yellowish. It can take the form of different colors. And then on the bottom, we see something called petechiae. And notice that petechiae and rash look a little different. The petechiae aren't necessarily raised. They are kind of in level with the skin. They're in the dermis. And so these are usually not associated with any type of rash, itching, or pain. So petechiae are a little bit different. And again, we'll talk more about this. At this point, I just kind of want you to be able to recognize and differentiate between the four of these. So moving on to the head and the neck, we're gonna take a look at the eyes, specifically the conjunctiva and the sclera, whether or not they're clear. We're going to talk a little bit about the red reflex. We're going to look at pupil assessment. Are the pupils equal, round, and reactive to light? That's PERRL. And we're going to look at visual acuity, which we determine through the Snellen vision exam. So let's talk about the conjunctiva first. Here we can see that this individual has some conjunctivitis. And we know this because we can see some redness around the mucosal layer. And this is the line outside, kind of around the sclera. We see some redness. We see conjunctivitis, which really just means, irritation, inflammation of the conjunctiva. And here, there are some different examples of types. So in the first example, we see a healthy eye, right? What an eye should look like. Nice, pretty blue retina, normal-sized black pupil, nice white sclera. We look next to that and we see bacterial conjunctivitis, where we see that redness, but we also see some drainage coming out, right? It looks like there's some exudate around that area as well, telling us that there could be a bacterial infection in the eye. On the bottom, we see a viral conjunctivitis where we've got a lot of redness and irritation. And then we see allergic conjunctivitis where we see the redness again still, but in this case we see kind of teary-eyed, right? So we see that there's like kind of some excess fluid around the eye, that the eyes are watery, and this is from allergic reaction to something. So those are the different types. The one that we're most familiar with is bacterial conjunctivitis, which we also call pink eye, which usually requires an antibiotic eye drop from the doctor's office. So now we're going to learn a little bit about checking the pupils. And in fact, you're going to learn about everything you ever wanted to know about checking the pupils from this video by Dr. Farmer. So let's just take a second and watch the oculomotor assessment video from Dr. Farmer.
This is Maui Community College, with a world of knowledge here at home.
So this is the old Tiki Eyes. It's also called the oculomotor assessment. So when you're assessing someone's eyes, first thing I look for is pupil symmetry. And here our pupils are equally round. Anisocoria means unequal pupils. And slight anisocoria is a normal variant in 25% of the population. And without iso, the same coria pupils. That's where anisocoria comes from. So slightly unequal pupils is normal in 25% of the population. Size is measured. We can use little charts with the spots that tell us whether it's 1 millimeter, 2 millimeters, all the way up to 10 millimeters. That's usually enough. And so when we look at pupil size, we look at symmetry and we measure. I like to throw this in. Pinpoint pupils. Pinpoint pupils, people on the effects of narcotics, opioid analgesics, can have pinpoint pupils. Parasympathetic nerve fibers from cranial nerve 3, the oculomotor nerve, provide the innervations for pupillary constriction. And if you go to the movie theater, all during the movie part before the Roman numerals come up at the end, but all during the movie, if you look at the Hollywood actors very, very carefully, you'll see that sometimes some of them have pinpoint pupils all the time. I wonder why. A blown pupil, that's what we used to call it. A blown pupil is a single dilated pupil, and it can be a sign of neurologic distress, trauma, swelling of the brain, bleeding around the brain, stroke, anything that's either going to shift the brain and stretch the third cranial nerve can result in a blown pupil. But history is everything because maybe they just went to the eye doctor today and got their pupil dilated for an exam. So history is everything in these types of exams, all exams. So at the bottom is my hand with a flashlight, a little pen light, shine it in people's eyes. And here we see fixed and dilated pupils. Fixed meaning they don't move, dilated meaning they're open. And fixed and dilated pupils means severe brain damage. This is a normal light reflex. Notice when the light comes on, both pupils are going to respond. And so the pupil that responds, that's the direct light reflex. And the other pupil is going to constrict as well in response to the light, and that's the indirect or consensual light reflex. And we can move to the flashlight to the other eye and see the same thing happen. The direct response occurs when the light is shined in that pupil. The indirect response is the other pupil responding to the light reflex. The indirect response is also called the consensual response. Symmetric direct and indirect pupillary reflexes reveal an enormous amount of information about the reflexes inside the brain stem. And that's why we do that. Just that test alone tells us an enormous amount of information about the brain stem, as long as you know how it's wired. But shining the light in the eyes and seeing that both pupils respond equally is more than enough. We hear about accommodation. I'm not sure anybody really knows what accommodation is. Accommodation was originally developed to detect tertiary syphilis. We'll talk about that later. That's a sexually transmitted disease. Modern antibiotic use has made tertiary syphilis very rare, but the eye exam for accommodation remains. Accommodation is more than just crossing the eyes. Crossing the eyes is called a convergent gaze. Accommodation is actually the pupillary reflex that occurs when focusing close. Actually, the whole thing is accommodation, but one of the most important parts of accommodation is that as the eyes focus close, the pupils get smaller. And this doesn't have anything to do with crossing the eyes because we can test absolute accommodation. If we cover one of the eyes and as the open eye focuses on something more close, the pupil gets smaller. So this is absolute accommodation. So those of you in the clinical setting will see PERRLA, pupils equally round, pupils equally round and reactive to light. And the A stands for accommodation. And if you're not going to do accommodation, then I don't even put the A at the end. But I do positive, negative, and absolute accommodation when I do accommodation reflexes. So this is a normal conjugate gaze. Conjugate means yoked together, moving together. Normal gaze. Eyes that move together are going to be able to maintain a single image as they track. And so this is called gaze, a conjugate gaze system. So I showed you conjugate gaze when the eyes move together. This is dysconjugate gaze. And so new onset dysconjugate gaze can be a serious neurologic problem. So always ask if they're having double vision. Something I do, something many people do, is if you look carefully, you can look at someone else or in the mirror, you can use the reflection off of their eyes as a landmark to make sure that the pupils move around that gleam in their eyes symmetrically. And here you can tell that the eye on the left does not move symmetrically with the eye on the right, and it makes it more obvious when we're looking at the gleam. Nystagmus, for lack of a better description, is like eye tremors. Nystagmus, which is a type of eye tremor, has many causes: drugs, dizziness, but this can also be a sign of cerebellar dysfunction, dysfunction of the cerebellum, part in the back of your brain that's also involved in balance. And so this is nystagmus. It's not a great animation of nystagmus, but if you see this, that's what it is. Something else to keep in mind are something called the oculovestibular reflexes. Oculo meaning eyes, vestibular is head movement. The vestibular system senses your head moving through space. That's why if you close your eyes and spin in a chair, the chair stops, you still feel dizzy. That's your vestibular system that makes you feel that way. And the eyes and your ear balance system, your vestibular system, are closely related to each other. If you look in the mirror or at the person next to you and bobble your head around slowly, you'll notice that your eyes can stay fixed on a certain part, on a certain point, as your head moves about. And this is because the oculomotor system is closely connected to your vestibular system. I want you to know what a saccade is. A saccade is an instant gaze change. As you look from one place to another, the vision centers in your brain will burst off. They'll shut off as your eyes move and come back on. And so that's different than gaze when you're following something with your eyes. A saccade is an instantaneous gaze change, like here and back. That's a saccade. Ptosis is eyelid droop. Your oculomotor system is designed to keep your pupils, keep your eyelids above your pupils. And so a single eyelid that droops over the pupil is ptosis. And this can reveal a neurologic problem, probably in the brainstem. Ptosis is usually accompanied by other signs of weakness as well. And so anyway, that's Tiki Eyes.
So I hope that video was helpful for you to get a really in-depth understanding of checking pupils. If you need to refer back to that, please feel welcome to. But we're just going to kind of blow through some pretty normal stuff in terms of pupils. And that is that the pupils need to be equal, round, and reactive to light. So here we can see some beautiful green eyes, and we can look at those eyes and see that not only are the pupils equal in size, they are round, and we can also see the reflection of light is also equal on both sides. So we're always looking for symmetry. We're looking to compare one side to the other. In terms of reactivity to light, as you saw in the video, when we flash a light into the eye, we expect the pupil to constrict, and that is a normal pupillary response. And normal pupils in daylight are around 2 to 4 millimeters, so we'll kind of say 3 is what we're considering to be pretty normal in daylight. But we know that the pupils dilate in the dark. So in darkness, pupils' normal size would be about 4 to 8 millimeters in the dark. So here we can see different examples of grading pupil size. And different things can impact the pupil size. We're not going to get into a lot of detail about that, but certain medications can cause the pupils to constrict and dilate. We know that when we turn the lights out in a room, that the pupils will normally dilate. But what we worry about is when there is a dilated pupil on one side and a pupil that is not dilated on the other side. And in a neuro situation, this could be meaning that the patient has had a major head trauma and they've got what we call a blown pupil on one side. However, we also need to find out history. History is very important as well, because I will show you here, we have a very live, perfectly healthy individual who has a dilated pupil on one side, and we can see that on the other side, it looks like it's about 3 or 4 millimeters, which is normal size. What's going on? He didn't have a traumatic brain injury. No, he actually went to the eye doctor earlier that day and he had some eye drops put in his eye that caused his pupils to dilate. So remember, history is very important when we are assessing anything about our patients. Okay? So if I saw something like this, I would ask the individual, hey, were you at the eye doctor earlier? Which would explain why maybe they had unequal pupil size. Okay? All right, so let's talk about use of the ophthalmoscope for checking red reflex. Red reflex is something that we check sometimes in our patients. And here is an example of what it looks like. So we take that ophthalmoscope, we flick that light on, we look into the patient's eye, we focus it, and what we're looking for is what's normal with the green check mark. We're looking for that nice red glow in the pupil. Abnormal is what we see on the other side, which is kind of this yellowing. And so what this test can detect is cataracts and also a retinoblastoma. And both conditions require an urgent referral to the physician. So if you ever check for a red reflex and there's an abnormal, you want to make sure we don't know the reason why that particular person has having an abnormal, but we do know that one of these possibilities is in the cards and we need to get them to go see a physician. Okay? The next thing we're going to take a look at is Snellen chart. This is visual acuity. So this is when we have someone in for a physical exam and we want to check how well their vision is, while they're seeing. And so here we can see the typical chart. And we can see that on the right, there are numbers 1 through 11, and then corresponding numbers 2020, 2100, 2070, 2050, 2040, 2030, etc. So let's talk a little bit about how we do this. When we are having the patient have their visual acuity checked, we have them stand 20 feet away from the chart. And usually first we have them read. We'll say start with line 1 with both eyes. Read line 2, read line 3, read line 4, and we have them go all the way down until they're having a really difficult time seeing, right? So if we get to like line 9 and they're really straining to see it, we say, is that difficult for you to see? Might be. And usually if they miss 2 or more letters on the line, we say that they've not gotten credit for that line. So for example, if they can't read all the letters in line 9, then I would bump back up to line 8 and I would say that they actually have 20/20 vision, okay? I'll give you another example. Let's say that with their right eye, they can read line 6 perfectly, but with their left eye, they miss a couple of letters in line 6, okay? Then actually, they would be 20/40 in their left eye because they could not read the letters in line 6 with their left eye, okay? So let's kind of define things a little more here. So children over the age of 6 through adults stand 20 feet away and read the lines. And we cover the right eye and then we cover the left eye to test the visual acuity in each eye, right? So the first number in the fraction, when we say 20/20, is the distance that the subject is standing from the chart. All right, so if we have someone that's under 6, we have them stand 10 feet away, but we still mark it as 20/20. So 20/20, the first number is the distance from the chart. The second number is of this fraction is how accurately the person can read the corresponding lines on the chart, okay? So this is where it gets a little bit tricky. So in 20/20 vision, which we consider to be perfect visual acuity, the person stood 20 feet away, okay? And the 20 on the denominator means that the subject can read the chart as well as a normal person can read the chart that's 20 feet away, meaning that someone with good vision can read that chart from 20 feet away. In 20/40 vision, so here's an example. In 20/40 vision, the 20 is still the distance in feet that they're standing away from the chart, but the 40 means that a person with normal vision could read standing 40 feet away what the person that you're testing couldn't read at 20 feet away, okay? So it actually means that they had a difficult time, and that somebody with perfect vision would not have had such a difficult time reading. And then, in fact, they could have stood further away from the chart and they could have seen it still. So I hope that makes sense to you. If not, send me an email. We'll talk about it when we get together and meet. There's also testing for color blindness. So I don't know how many of you out there are colorblind, but I can see the number 8 here, plain as day, because I am not colorblind to the color green. And in this plate, I can clearly see the 2 and the 5 because I don't have any color blindness. So these are called Ishihara color plates, and we use these when we are determining whether or not the individual has color blindness. So I think that is all we are going to cover for today. Next time we come back, we're going to look at some other details about physical assessment.